Let's talk about asthma and pregnancy. Um, Asthma can be affecting 8% of pregnancies. Severe or poorly controlled asthma is associated with prematurity, need for C-section, preeclampsia, and growth restrictions. Medications used in asthma, we have long-term control, such as inhaled corticosteroids, cromolyn, long-acting beta agonist, theophylline, and oral corticosteroids. Rescue medications include short-acting beta agonist and also oral corticosteroids. Some of the labor medications that can interfere with asthma, uh, non-selective beta blocker or carboprost or hemobate may trigger bronchospasm. Maxolfe is a bronchodilator. Indomethacin can induce bronchospasm as well. Asthma severity classifications. We'll have a little table here. So we have intermittent, which is less than 2 days per week or less of symptom, nighttime awakening twice per month or less. No interference with normal activity. The FEV1 or peak flow is 80% or 80% of personal best. For mild persistent, we have symptom frequency greater than 2 days per week, but not daily. Nighttime awakening more than twice a month with minor interference with normal activity. The FEV1 ratio, FEV1 percentage is still greater than 80%. Moderate persistent will have daily symptoms more than once a week, nighttime awakening, some limitations to daily activity. FEV1 is 60 to 80%. Severe persistent, we have symptoms throughout the day, nighttime awakening 4 times per week or more, and we have extreme limitation on normal activity 4 times a week. Wow. And FEV1 is less than 60%. Forced expiratory volume is less in the first second. Alright, so that's the classifications. Effects of pregnancy on asthma. Mild asthma, there is a exacerbation rate of 15% with 2% hospitalization rate. Moderate asthma exacerbation rate is 25% with hospitalization rate of 10%. Severe asthma exacerbation rate 50% with hospitalization rate of 25%. Diagnosis, symptoms. It can be diagnosed through symptoms, wheezing, chest cough, um, shortness of breath, chest tightness. It's usually worse at night and can be triggered by some kind of triggers. Um, if the airway obstruction on spirometer can be improved more than 12% with a bronchodilator, and that's also diagnostic. So the FEV1 increases 12%. How do we assess these? How do we assess asthma during pregnancy? We can use spirometer is preferred. Peak expiratory flow measurement with a peak flow meter is also sufficient. Some people get allergy shots um, because allergy immunotherapy can improve asthma in patients with allergies. However, anaphylaxis is a risk of allergen injections, and it can be associated with maternal or fetal death. So if you're already getting maintenance dose of allergy therapy, then we can continue. However, starting therapy is not recommended during pregnancy. Rescue therapies. Patient should use up to 2 treatments of inhaled albuterol, 2 to 6 puffs, or nebulized albuterol at 20-minute intervals. This can be done at home and self-administered. If the symptom does not improve or um, this can be done if the patient is experiencing symptoms or 20% decrease in the peak expiratory flow rate. However, if the symptom does not improve with the rescue therapy, then patient needs to go to the hospital. First line controller therapy for mild persistent asthma. Um, Inhaled low-dose corticosteroids is first line. Budesonide is the preferred corticosteroid. We can use 20 micrograms, 1 to 3 puffs as the, this should be daily, huh? For the first line controller therapy. If you have moderate persistent symptoms, then you might need to use medium dose inhaled corticosteroids, uh, budesonide 20 mics, 3 to 6 puffs. Or you can use a low dose corticosteroids and a long acting beta agonist. Severe persistent, you might need to use a high dose inhaled steroids plus a long acting inhaled beta agonist. Salmeterol 1 puff BID. Add-on controller, so other medications I can use. Long-acting beta-2 agonist is preferred for add-on. Fewer these beta agonists has fewer side effects than theophylline, and also theophylline requires serum monitoring and has limited data on pregnancy. So salmeterol or formoterol are the two long-acting beta-2 agonists that can be used. Acute asthma assessment. So obviously, if the patient presents to the hospital and after the initial treatment, if the FEV1 is greater than 70 and is sustained greater than 70 for 1 hour, um, and the fetal heart tracing is category 1, then patient can be discharged. If the FEV1 is between 50 to 70, then we individualize the treatment, either continue treatment in the ER or discharge, or patient should be hospitalized. If the FEV1 is less than 50, then hospitalization should be done. If the PCO2 is greater than 42 millimeter mercury, patient should be in the ICU. Discharge regimen. Patient should be discharged on a short-acting beta agonist, 2 to 4 puffs every 4 hours. Oral corticosteroids, 50 milligrams for 10 days. Inhaled corticosteroids should be started, and patients should be followed up in 5 days. Fetal surveillance for moderate to severe asthma, serial growth, can be started at 32 weeks. Intrapartum asthma meds should not be discontinued during labor. If taking oral glucocorticosteroids, patients should have IV corticosteroids such as hydrocortisone 100 milligrams Q8 IV during the labor and then for 24 hours postpartum to prevent adrenal crisis. Regional anesthesia is reported to incur 2% incidence of bronchospasm as well. Breastfeeding, use of prednisone, theophylline, inhaled corticosteroids, beta agonists, and cromolyn is not contraindicated during breastfeeding.